Okay, do you want to start? Do you want to go? Yeah, project, perfect.
So good afternoon, everybody. I'm going to present the paper that just recently got published last month on the ADA Diabetes Care journal. It's a French study called the RELIEF study, looking at the drops in the rate of acute diabetes complications in people with type 1 and type 2 diabetes after initiating the flash glucose monitoring. Now, initially, so the regular blood glucose monitoring is an essential part of diabetes care, and poor control, both hypos and hypers, can result in hospital admissions. And there's a significant healthcare burden and impact on patients' quality of life, and also there's financial implications with that come with these admissions. Now, I just wanted to briefly go through the current NHS England criteria, the local criteria for being approved for this intermittently scanned continuous glucose monitoring or flash glucose monitoring that came in place in April 2019. It pretty much is geared for all patients with type 1 diabetes who meet certain criteria. The first main one being those having to test or are testing up to 8 times a day. That can be demonstrated on their meters. There's probably an economic, it sounds more economically savvy to have a 2-weekly sensor as opposed to having 8 test strips a day. Other indications are those with type 1 diabetes having severe hypos or hypo unawareness, if deemed appropriate after being considered for other first-line options such as Dexcom or insulin pumps. Type 1 diabetes patients who are pregnant automatically qualify, and also type 1 diabetes patients who require support and require carers and who have occupational reasons that need a trial of flash glucose monitoring. Now, once they meet the criteria, they need to continue to be able to be eligible for continued NHS funding. They need to they need to meet certain further criteria, which is they need to attend regular education if they've not already done a structured education program, and also they have to have regular diabetes reviews by a specialist team, and they need to have sensor use of at least 70% of the time and scanning 8 times a day. There also needs to be an objective evidence of the benefit of using this flash glucose monitoring in terms of improvement in HbA1c, improvements in terms of hypoglycemia events, and reduction in the number of DKA episodes resulting in admission. Now, across the channel in France, they are a bit more liberal in terms of what criteria patients should meet. And the main criteria is that they need to be having multiple daily injections of insulin, whether it's type 1, they don't break it down to whether it's type 1 or type 2, as long as they'll meet the criteria of them they have multiple daily injections of at least 3 injections per day or are on insulin pump. And this came in place in June 2017. Worth mentioning is the French National Health Claims Database called the SNDS. From the paper itself, it was quite robust. It records a lot of patients' administrative data, such as outpatient visits, the medications being dispensed. They look at the hospital admissions and the diagnosis on admissions that are being coded in the hospital notes, and also they would record the causes of death or other hospital-related information. Now, in the recent 3-4 years, a lot of evidence is coming up in terms of the efficacy of using Freestyle Libre or the flash glucose monitoring in managing acute diabetes complications. Somewhere not far from here in Scotland, they managed to show that there was an overall reduction in diabetes DKA-related admissions, but there was also an increased time spent in hypoglycemia recorded in that study. Another study in Belgium, the future study, showed that there was a reduction in overall hypoglycemic events, but there was no actual change in HbA1c or DKA-related events. And so there's a lot of these studies had showed mixed outcomes, as well as the numbers that were included in the studies was small, at approximately 1,000 patients. So the main aim and objective of the French study here was to see that how the use of Freestyle Libre has impacted on acute healthcare outcomes after 1 year. And the way they recorded this was looking at the diabetes-related complications resulting in hospitalization or admissions. The four complications being recorded were DKA, hyperglycemia, and diabetes-related coma. Now, in terms of how they've designed the study, it was a longitudinal retrospective cohort study, and the way they included all patients with diabetes, whether type 1 or type 2, who were newly commenced on the Freestyle Libre between a period of 5 months from August 2017 to December 2017, keeping in mind that the flash glucose monitoring became available, was funded by the government from June 2017. They also identified patients who, with diabetes, who were at least receiving medications in any time in the 2 years prior to starting the Freestyle Libre, or were having medications in the 1 year after starting the Freestyle Libre. One thing they did mention was that they weren't able to differentiate newly diagnosed diabetes who were first presenting as DKA. So the first presentation with DKA was recorded as admission to hospital pre-Freestyle Libre, and then they continue with treatment in that time period. They've excluded patients who did not have more than one prescription or one dispensed prescription of the Freestyle Libre sensors, and they excluded patients who did not have who are less than 18 years, who do not have a long history of insulin or medication use, diabetes treatment use in the time period. And they relied heavily in terms of collecting data from the National Health Claims Database, the SNDS database, both 1 year before and after the starting the Freestyle Libre. So this is a diagrammatic representation. They're looking at how they've selected patients. So the first block that mentions is the June-July 2017. That's when the Freestyle Libre became available on the healthcare system in France. But they started collecting data from August till December 2017, the 5-month period, and they looked at the data. So once they started the Freestyle Libre, that was counted at T0, and they looked at the data 12 months before this time period and 12 months after. And different patients will have a different timeline depending on when they actually started the Freestyle Libre. They also, as part of the analysis, they were looking at the average daily use of test strips or self-monitoring, and they looked at the number of blood glucose strips being dispensed from the database, and they averaged it out into how much test strips they were using per day. And the assumption here was that all the test strips being dispensed were being actually used. And the way they collected data regarding hospital admissions or diabetes complications was from the SNDS database that was being coded in the hospital notes and recorded in the database. This was looked at both 12 months before and 12 months after Freestyle Libre start. Now, one thing I need to mention was that the database doesn't actually record the type of diabetes the patient has. They just classify it as in one group as type 1 or type 2. But the authors, they use an algorithm to identify patients and classify them into type 1 or type 2, depending on the patient characteristics, types of treatment they've had, and certain hospital codings that would have come on the database. An important thing to note here is in the paper, they have not used any statistical analysis or any significance testing, and we're just using the crude numbers to compare events before and after. So in terms of results, the first table looks at the demographics of the population, and you can see that the total number of people included were 74,000, and a majority of those patients who were on Freestyle Libre, more than half of them had type 2 diabetes, and 33,000 had type 1 diabetes. Another thing to mention was the type of diabetes treatment these patients were. As you'd expect with type 1 diabetes, the majority, nearly 94% were on insulin or insulin and other medication, but there was a small portion of patients who were on non-insulin treatment or oral medications, suggesting that this might be misclassified as type 1 when they actually were type 2. Also, they were looking at the type of diabetes treatment or in more detail. And they looked at the type 1 diabetes patients. Majority of them, nearly 2/3 of them, were on multiple daily injections, and 1/3 of them were on insulin pumps. Now, the first chart, it looks at the acute diabetes-related complications and admissions for patients with type 1 diabetes, both before and after. The blue bar representing before Freestyle Libre and the red bar representing after Freestyle Libre. And important mention is that the total reduction of all complications and admissions, there was a reduction from 6.3 to 3.2, nearly the admission rates were nearly halved. And this was majorly, the main contributing factor was the reduction in the number of events related to DKA. So that reduced from 5.4 to 2.4%. And similarly for type 2 diabetes, also the frequency of hospitalization was not that high in type 2. There was also a notable reduction from both before and after. And although the proportion they're using, they're mentioning is 52% reduction in DKA, the actual reduction in the actual numbers was from 1.7 to 0.8%. Same with hypoglycemia, the reduction, although it's mentioned as 10%, the actual reduction is only from 0.7 to 0.62, that's 0.08%. Now, as part of the analysis, they looked at, they categorized the patients, both type 1 and type 2, into how frequently they were self-testing. And they categorized them into those who are using no test strips per day, those who are using less frequently, and those who are using more frequently of more than 5 test strips per day. And they were equally distributed, around 25% between the four categories. And looking at the total study population, the diabetes complication rates for those who are not frequently testing was much higher. This the blue bar representing before Freestyle Libre was started. So the complication rate was much higher in those patients who are not frequently testing or not testing at all. And since starting the Freestyle Libre, there was a reduction from 6.1% to 2.8% in terms of hospital admissions with diabetes complications. And interestingly, those who are testing it even more frequently, of more than 5 tests per day, they also had a high complication rate, and there was a notable reduction in the complications after starting Freestyle Libre. Now, looking specifically at the type 1 diabetes population, which was around 33,000 patients, looking at those who are not testing frequently or testing less than once per day, there was a notable difference from 9.1% to 3.8%, nearly half, more than half reduction in complications and admissions in patients who are not testing more than once, or not testing at all. Similar observation was seen in those who were testing less frequently, but it was much more notable in those who were not testing at all. And in type 2 diabetes, the total number of patients being around 41,000. The reduction was also seen across all categories, especially in those who were not testing at least once a day. They also, as part of the result, they included a multivariable analysis of diabetes complications, the risk factors that would be, the odds of, the risk factors that would more contribute to hospital admissions. And they identified that being of young age, of less than 25 years, was more of a risk factor of being admitted to hospital with complications. And this risk did not change after starting Freestyle Libre. The risks remained pretty much the same both before and after starting the Freestyle. And also looking at what did change, however, often was patients who are on multiple daily injections. The risk of being admitted or having a diabetes-related complication and admission was higher for those who are on multiple daily injections, but that risk reduced after the starting of Freestyle Libre, suggesting that they may have been able to more tightly control the diabetes with continuous glucose monitoring or flash glucose monitoring. The same applied to those who are testing much more frequently, using multiple test strips before starting Freestyle Libre, suggesting that those who are testing more frequently had unstable blood glucoses, and with the help of Freestyle Libre, that risk, the risk were reduced after starting freestyle. One of the tables I mentioned in the supplementary documents was how persistent, or how many of the patients continued with Freestyle Libre at 1 year, and those who were not compliant. The total compliance for all categories was quite high at 98.1%, but specifically looking at those who were not testing at all with the test strips prior to Freestyle Libre, the compliance with the Freestyle Libre was quite high at 97%. So in conclusion, the main findings were that there was a marked reduction, I can't say significant, but there was a notable decrease in diabetes-related complications and admissions in 12 months after starting Freestyle Libre, especially in the rates of DKA-related admissions, and that reduced from 5.5% to 2.4%. That's nearly more than half of case reduction. And also all diabetes, there's also a reduction in all the diabetes complications, including hypos and hypoglycemias and diabetic comas. Small improvements were also seen in those patients with type 2 diabetes after starting Freestyle Libre. Now, of important note was that those patients were deemed to be poorly compliant with self-monitoring as per the average number of daily test strip use, showed that they benefited the most, as shown by the reduction in all complications in these patients from 9.1% to 3.8%, especially in type 1 diabetes. And there's an overall reduction in complications since starting Freestyle Libre in the whole study population. So also, those are some of the risk factors that were attached to hospital complications, such as multiple daily injections or frequent blood glucose testing prior to Freestyle Libre. There was reduction in these there was a reduction in these risks that was contributing to their hospital admissions, presumably because they were able to test more frequently, able to get more stability in their diabetes, and hence they were able to get more tighter control and have better diabetes related outcomes. And continuation of Freestyle Libre was quite more than 98% in the majority of the population, and especially in those who are not deemed to be compliant prior to starting the Freestyle Libre. The limitations of that the authors mentioned was quite a few. They did not have a control group, and there was perhaps selection bias. A lot of the patients who would have got early access to the Freestyle Libre on the state funding would be those who are at more risk of complications. So the population likely would be representing the high-risk patients to start off with. And also they're not taking into account any confounding factors. So with start of Freestyle Libre, they might have had more intensive input, more structured education, which might have also impacted on the rates of hospital admissions and complications. As previously mentioned, they weren't able to exclude new diagnosis of diabetes with first DKA admissions, in the sense that patients who were first diagnosed and were treated appropriately might not end up having further complications if they were continued on self-monitoring. So there is a possibility of overestimated admissions and complications before starting the Freestyle Libre. The SMDS, the health claims database, looks at just the administrative data, but doesn't look at the clinical data, such as the HbA1c, improvements in HbA1c, or the actual usage of the Freestyle Libre, how frequently they were using the system, and how much time they were in range. And the database was heavily reliant on the hospital coding of the complications and admissions. And only complications that resulted or ended up in hospital were being recorded. It doesn't include the minor complication experienced by patients. One thing I mentioned was that nearly all of the authors were being sponsored, and the study was funded by the Abbott Diabetes, which were the manufacturers of Freestyle Libre. So there is an element of bias that comes with the study. And in terms of strength of the study, it was a large-scale study, including around 71,000 patients and nearly 31,000 type 1 diabetes patients. And it effectively shows real-world data in terms of how an intervention has impacted on diabetes admission both before and after starting Freestyle Libre, and suggests that there are some long-term health economic benefits associated with better diabetes control with Freestyle Libre. So how will it affect practice? One of the things that I thought was that it may influence the current NHS England criteria for those patients who are requiring to test more than 8 times a day to be able to qualify for the Freestyle Libre. The most benefits, as shown by the results, were experienced by those who had less frequent testing. And so the requirement of having at least 8 tests per day may no longer be applicable. And also maybe a new indication for type 1 diabetes patients having frequent decay-related admissions, as shown by the results that those who are having one of the impacts of starting Freestyle Libre was the nearly halving of the decay-related events in patients after Freestyle Libre initiation. Thank you. That's the paper.
Thank you very much. That was really clear. I did see the National Director for Diabetes on the line a minute ago, but I think he might have gone. I don't know if I want to say anything about the 8 times a day. It's a financial thing, really, the 8 times a day, because the money you save is 8 sticks worth, but it's quite painful.
I think I only want to make. I might have missed it, Vinit, but what are the criteria for giving Freestyle Libre in France? How do they compare to our criteria?
So from the French criteria was quite open, in a sense. Any type 1 or type 2 diabetes patients would qualify for Freestyle Libre as long as they were having 3 multiple daily injections of insulin. But according to the type of data they've collected, a lot of patients were also on oral medications or non-insulin related medications. So theirs were less, overall it seemed they were less restrictive.
Can you still hear us? I've just changed the microphone. Can you hear us?
Yeah.
No, they can't.
Yeah, I can. Yeah.
Yeah, interesting. Because of course it could be seen as an advertisement for by Abbott, because that's a financial thing. But I mean, it does have some good. I do love the way they say we're not putting statistics in this paper. That's a new. I must try that. Write paper and say we're not going to even try p-values.
Because you can't say any significant difference. I had to keep reminding myself. I have to say there was a notable or a market difference.
Yeah, I mean, look, the problem is, of course, that there's no control group. I guess that might be why they didn't try. But it looks, I bet you if they put stats through it, it would be quite significant. I mean, halving of numbers, unless there's very, very wide error bars, that's possible.
I don't think it matters about that. I mean, it's a huge data set, and they've got pre and post initiation data, and there is a reduction. I think from my point of view, I'm more interested in whether that reduction is sustainable, because we know a lot of these technologies drive behavioral changes, but they're often short-lived. And also the cost effectiveness of those reductions in complications versus giving the technology in a more widespread way than we're certainly delivering it here. Oh, Nick's online. Nick?
Hello. I was going to say, so there is one weird thing about this analysis. So the SNDS database in France has well over a decade's worth of data. And if they had, as Karim suggested a minute ago, if they had included the variance of DKA rates from their database, then they would have been able to show whether that year of flash usage significantly differed outside of that variance. So the data are there, but they chose not to use them, which I just find slightly odd. And you can argue that then that you wouldn't get such a clear pre and post with such equipoise of treatment period, but it would have given them the opportunity to show a significant impact, and they didn't take the opportunity. So I think there's something weird in that.
Sorry, Nick, what do you mean by the variance? You
So-
mean
so
the
if you
ups
took-
and downs over the previous
Yeah.
years?
So if you took the annual rate of DKA and severe hypoglycemia and then assess the rate of the year on Libra, you would be able to show whether that was significantly differed from the previous 10 years variance, but they chose not to do that.
Yeah.
Which is maybe for a good reason, but may not be, don't know. So I just think that's a slightly odd decision. And I'm still intrigued as to how they had coma without severe hypoglycemia. How did hypos not change, but coma did? What sort of a coma was that?
They didn't specify. They just say they were coded as diabetic coma.
I know, but the coding's odd, isn't it? So if you have coma, you're either in DKA or you're in hypoglycemia. So that would imply that if there's a difference in DKA and a difference in coma, but no difference in hypoglycemia, those comas were DKA associated. So FLASH is not changing hypoglycemia presentations, and that fits with the Edinburgh data, which suggested a threefold increase in presentation with severe hypoglycemia with FLASH. Smaller numbers, different way of data collection, and different way of implementing FLASH, but it's a slightly odd analysis. And the other minor point, but that slightly winds me up, is when people put important in the title of their own paper. Let the reader.
I think the cost is going to be an issue, and that's the numbers have come from 8 sticks. You save that money by using the Freestyle Libra. So if you use 7 or less, then it's going to cost the country. And the question really is there a real benefit? Do you actually save admissions, or is the error bar so wide around it that actually it's not really a genuine reduction?
I think also in the Edinburgh data, they showed that the biggest reduction in HbA1c occurred in people who had higher HbA1cs to begin with. So given the unselected nature in which they've given this, and we can't really account for healthcare professional bias and who gets these devices, it might be that the low-hanging fruit really accounts for the reduction in terms of those people at risk of these complications, but in subsequent years that relationship is attenuated.
Yeah. We need Jonathan, don't we, to tell us what he thinks. He was here a minute ago, I think he's gone.
Oh yeah.
Any other question?
Not sure.
No?
No.
What are you going to say?
No, I didn't have a clear grasp, because the thing was that the inclusion criteria, maybe it's the translation from French to English, but there were a lot of errors in terms of trying to interpret how they included the diabetes patients. At one point, they were saying those who were treated for at least 6 months, and then they went on to say patients who were being treated for at least 2 years. So there was a lot of the methods were, the way they designed it wasn't very clear on the way they've published the paper. In a sense, they might have not taken into full account of all the finer details.
I mean, it's possible, I don't know, it's possible that they just interrogated the database and did a kind of audit and then picked the thing they wanted and then published it. That is a slight worry. Because of course, if you're a drug company, you're not going to choose any data that's not selling your message, and they have a clear financial benefit, and they've declared it. But we need to be a bit careful before we just go out saying everyone should be using this. Although, I mean, to people who prick their finger 8 times a day, I think it's forget the money. I mean, just the pain of it. Yeah. Thank you, Vinit. That was very important that we know about this study. Very helpful.
Also, one thing just to mention was although there a lot of the, especially in the abstract, they mentioned there's a 50% reduction, there's a 50% or 30% reduction. the actual percentage or the frequency of events, the reduction is not that impressive. So the reduction, for example, some of the hypoglycemia rates or the coma related rate, they're only reducing from 1.5% to 0.8%, for example, and that's classified as nearly 40% reduction. So I don't know. I mean, yes.
No, I was going to say that's a common thing that you see in papers. You see a reduction from 1 to 0.7, and that's a 30% reduction. But yes, that's a really important point to bear in mind.
So you're saying it's low to low.
Yes, and there's lots of papers that do this. It's widely carried out, unfortunately. It's to maximize their message, even though it might be a wrong message. That's the important thing.
Yeah.
Yes, thank you for that, Vinit. That's an important caveat.
Thank you all.
Okay, any other? Thank you all. See you next week.
Thank you very much. Excellent.
Yes. Got a nice view there. Okay, so clinic, I guess. Then turn my-
So I might just check while you're here. Do you know who's here next week? I might have to